Thank you everyone for attending my presentation. It is an honor to have received AOTF's Early Career Research Excellence Award and have the opportunity today to share with you my program of research focused on increasing support for care partners in geriatric health services. I want to start my presentation today by first acknowledging support from the National Institutes of Health, the UW Health, as well as continued encouragement and stimulating discussions with my participants, students, and close colleagues. And second, I'd like to express my deep gratitude to some of my closest mentors, Drs. Wendy Wood, Elizabeth Skidmore, Julene Rodakowski, and Dorothy Edwards. Thank you all for your endless advocacy and challenging guidance throughout my career. My presentation will consist of 4 main sections, which will include some background information, a brief description of my care partner work, future directions, and some lessons I've learned along the way. So I'm first going to start by presenting some background information. To establish the need and guidance of my work, I want to introduce everyone to Mrs. T. Mrs. T is a 75-year-old white female, retired teacher, widow, and mother to 2 daughters who live nearby. She has hypertension and recently has presented with challenges in planning, confusion, and started withdrawing from meaningful social activities. One day, when her daughters were visiting, Mrs. T complained of severe hip pain. They immediately took their mother to the emergency room and soon learned from an x-ray that Mrs. T had broken her hip. Subsequently, Mrs. T was admitted to the hospital for hip surgery. During surgery, her daughters left the hospital to return to work. Just 2 days later, Mrs. T was discharged home alone with posterior hip precautions. And sadly, that next day, Mrs. T fell while getting in the shower, which resulted in another emergency room visit and a hip dislocation. All things considered, with the case of Mrs. T, you may be asking yourself, why was her family not more involved in her care? Unfortunately, Mrs. T's case is not uncommon and contributes to the growing need to recognize caregiving as a public health crisis, as observed by the recent headlines portrayed on this slide. If you haven't provided some level of physical, emotional, financial, or social support to an older adult loved one, chances are you will in the near future. In fact, today, more than 53 million Americans have stepped up to provide unpaid care to family, friends, and close neighbors. Research continually shows that caregivers, herein referred to as care partners, are at increased risk for physical health, emotional and mental health, financial and work-related problems. And this is compounded into an even more complex matter given associated challenges with the COVID-19 pandemic. From this figure, we can see the complexity of caregiving is a result of many interrelated factors. Care provided can vary in type, nature, and duration, and is influenced by unique circumstances of the older adult care recipient. Although caregiving roles can vary widely, there is a prototypical trajectory for care partners of older adults, especially those with chronic conditions. This caregiving trajectory may begin with an emerging awareness on the part of the care partner that there's a problem, which necessitates sporadic or temporary assistance, including taking the older adult to healthcare appointments, communicating with providers, and monitoring the older adult's functional limitations. Over time, this caregiving evolves into increasing care needs, which requires assistance with household tasks and even self-care. End-of-life care may involve placement into a long-term care facility or enrollment in a hospice program. Referring back to Mrs. T, her daughters may have started off their caregiving journey by delivering groceries on a weekly basis. But then suddenly, they were required to shift and provide more intense recuperative care following their mother's readmission and hip dislocation, feeling unprepared to do so. While this shift may have been surprising to Mrs. T's daughters, it's not surprising for healthcare systems as many continue to shorten lengths of hospital stays. Recognizing the need to better support care partners in their caregiving role has been the central basis of my work. To better support care partners as a researcher, I believe it's necessary to look at structure, process, and individual level factors that contribute to the complexity of caregiving. Structure level factors are those that affect the context in which services are delivered. These can include policies, payment models, and culture. Process level factors are those that affect service delivery, and these can be workflows and decision support tools, to name a few examples. And individual factors of either the older adult, care partner, or provider can include those basic demographics, preferences for care, and existing knowledge and skill set. As a postdoctoral trainee, I completed a couple different studies to better understand and document some structure and process level factors affecting the lack of care partner involvement, like Mrs. T's daughters. My very first study was a systematic review, which allowed me to explore assessment tools used to identify the needs of care partners during hospital-based care. I found that very few, indeed only 4, tools were actually designed for the hospital setting in mind, captured more than one type of care partner need, or provided support for providers' clinical decision-making. My next study enabled me to further uncover the need for standard tools, workflows, or strategies focused on involving care partners in hospital care. So in particular, my team's mixed method quality improvement study examined a large academic medical center's compliance of the Caregiver Advise Record Enable Act post-implementation within their system. This state law, known as the CARE Act, mandates hospitals to ask patients on admission if they want to identify and record the name of a care partner in their medical record, notify that designated care partner of the patient's upcoming hospital discharge, and provide that care partner training on how to complete caregiving tasks that will be necessary to perform once the patient is home. Unfortunately, our analysis of observations, interviews, as well as electronic health records revealed that very few care partners were identified on admission, notified of the patient's upcoming discharge, or received appropriate and necessary training. My team's findings are problematic because literature suggests that there are many advantages of including and training care partners. So for example, evidence indicates that integrating care partners in care processes helps reduce risk of older adults' hospital readmission rates and increases both the experience and health of older adults and their care partners. So given that we know there are benefits of including and training care partners, I decided that my next study should focus on helping systems solve some of those previously mentioned structure and process level problems. Over the past 2 years, my team has developed and validated the Care Partner Hospital Assessment Tool, also known as CHAT. The purpose of CHAT is to screen care partners for potential information or training needs that could be delivered by various healthcare providers. This screening involves gathering preliminary information about the care partner's background, plans and preferences for providing care, and skills and supports related needs that the care partner may have surrounding the patient's admission. So as you can see here, the CHAT applies a sequential screening referral pathway that tailors referrals to address their stated preferences and unmet needs for post-discharge preparedness. After surveying 23 experts in gerontology, caregiving, and health services, a 22-item chat was accepted by having an item content validity index at or above the acceptable cut point of 78% and a scale content validity index of 85%. These findings demonstrate strong content validity of the chat. We also interviewed healthcare administrators, providers, and care partners of hospitalized older adult patients to learn their opinions of the chat, as well as suggestions for implementing the tool into hospital workflow. All participants agreed that the chat is an appropriate length for the fast-paced nature of the hospital setting, would not be disruptive to patient care, aligns with the mission of delivering patient and family-centered geriatric care, and could better prepare care partners to fulfill caregiving tasks. Many participants also describe chat as a low-risk, high-reward opportunity. So in particular, our participants thought that the chat could help improve several important and commonly used quality indicators, such as patient family satisfaction of care and health service utilization outcomes like readmission rates and emergency department visits. My team's work has several positive implications. It departs from contemporary patient-centered geriatric care practices by integrating care partners into health systems and services. It provides a validated clinical decision support tool designed to facilitate the timely inclusion and training of care partners during hospital-based care processes. It bridges the gap between policy and practice by offering providers guidance on how to identify and better prepare care partners of hospitalized patients. And it has strong potential to improve health and service utilization outcomes for both older adults and their care partners. So let's revisit the original case of Mrs. T. Again, Mrs. T is a 75-year-old white female, retired teacher, widow, and mother to 2 daughters that live nearby. She has hypertension and has recently presented with challenges in planning, confusion, and has started to withdraw from meaningful social activities. One day when her daughters were visiting, Mrs. T complained of severe hip pain. They immediately took their mother to the emergency room and soon learned from an x-ray that Mrs. T had broken her hip. Subsequently, Mrs. T was admitted to the hospital for hip surgery. Before Mrs. T's daughters left the hospital to return to work, they were provided an opportunity to complete the chat. While completing the chat, the daughters realized they would need much more information and training on how to help their mother before she gets home. As such, they let their mother's nurse know when they would be able to come back to the hospital and also jotted down their availability on the chat. In the meantime, the nurse shared the daughters' responses with Mrs. T's care team during the next shift change. Mrs. T's daughters returned later that afternoon and received more information from pharmacy on how to fill their mother's prescriptions, therapies on how to reinforce their mother's hip precautions during mobility, and set up the home environment to increase her safety and independence during personal care tasks. 2 days later, Mrs. T returned home with her daughters. Her daughters went over some new adaptive equipment, as well as the pill box setup, and also organized a family visitor schedule to further prevent adverse outcomes from happening. Ultimately, we can see the positive implications of this revised case of Mrs. T. At this point in my presentation, I've illustrated ways in which we can better support care partners in geriatric health services through the case of Mrs. T. Nevertheless, Mrs. T represents just one case that is too common among our aging population. Moving forward, I plan to concentrate on one of the fastest growing threats to health in the United States. More than 5.8 million older adults in the United States live with Alzheimer's disease and related dementias, also referred to as ADRD. Compared to other older adults, those living with ADRD have twice as many hospitalizations and stay nearly a day longer. Further evidence indicates that older adults living with ADRD discharged from hospitals are at higher risk for readmission within 30 days. So with that said, it's not surprising that more than 11 million care partners provide nearly 15 billion hours of unpaid care annually to older adults living with ADRD. A recent comprehensive review of the evidence for care interventions for older adults living with ADRD and their care partners identified only 5 studies focused on approaches such as decision support tools or other technology to assist care partners of older adults living with ADRD. And none of the studies developed or examined a decision support tool to facilitate the inclusion and training of care partners within hospital-based care delivery processes. So as you can see from the recommendations listed on this slide, this is a critical need which is being recognized by and is in line with not only the National Alzheimer's Plan, but also the National Institute on Aging. Given my preliminary chat work and need to better support care partners of hospitalized patients living with ADRD, I submitted a K-23 Career Development Award application earlier this spring to the National Institute on Aging. I hope to soon have funding that will allow me to first adapt chat for ADRD care and then complete a pilot randomized control trial to evaluate feasibility and estimate the size of the effect of the adapted chat on caregiving preparedness compared to usual care. Through these research experiences, I will gain more expertise in participatory human-centered design, ADRD hospital-based care, clinical trials and biostatistics, as well as ethical and regulatory standards for this vulnerable population. Before I end, I want to share some lessons I've learned from my training and early career research experiences that I've presented so far today. My hope is that these lessons will help other early career occupational therapy researchers realize their full potential for success. First lesson, build your village. This village should consist of those who not only teach you about research, but support you emotionally and hold you accountable for your goals. Second lesson, be patient. As many of us are aware, studies do not happen overnight. Papers and grant proposals are often not accepted on the first, second, or even third submissions, and it can take quite a bit of time to master certain skills. A research career is a journey full of unexpected highs and lows, so develop a growth mindset. Third lesson, follow your passion. Be picky when you choose what you do so that your work really resonates with you. As Confucius said, choose a job you love and you will never have to work a day in your life. And fourth lesson, pay it forward. Take time to observe, listen, and support others interested in research. This will help ensure the inclusiveness of the occupational therapy profession by creating a sense of connectedness and positivity. That brings me to the end of my presentation. Thank you all so much for tuning in, and please do not hesitate to reach out to me with any questions about the studies presented today or the lessons learned via email or social media accounts on the slide. Thank you.